Hello everyone, so today's tutorial is on high yield lower GI and surgery. So the conditions we'll cover are inflammatory bowel disease, functional bowel disorders, celiac disease, colorectal cancer, hereditary cancer syndromes, causes of small and large bowel obstruction, hernias, ischemic bowel conditions, anorectal disease and stomas. So obviously this is not the full core conditions, but these are really high yield stuff. So case one, we have a patient, young lady presenting to the GP with 2 months history of diarrhea and tummy pain, which is fairly severe that it's affecting her ability to work. So what kind of differentials do we have? Obviously there's a lot. So we have gastroenteritis, which is kind of obvious, but it's easy to miss asking about travel history and any like barbecues and things they've been to. So ask about the time details quite well, because that's how you differentiate with a lot of tropical diseases. IBD, hypothyroidism, medications, so things like metformin, which is quite common, can give you stomach issues, dietary changes, any new stresses, and obviously IBA. So we'll start by talking about inflammatory bowel disease, which is split into Crohn's disease and ulcerative colitis. And these can be quite difficult to differentiate, so we'll talk about them in detail. So Crohn's disease is a chronic inflammatory GI disease, and it's characterized by transmural granulomatous inflammation, which means it goes through the whole tissue, unlike ulcerative colitis, which is more membrane level. So it typically presents in young adults, and when you think of the whole GI tract, they appear in skip lesions, which means it can go from the mouth, presenting as ulcers, or it can go all the way down to the anus, presenting as skin tags. So most of the time, the most severe part will be the ileocecal valve, which is in your right lower quadrant. So how would they present? Usually they'll come in with diarrhea, especially if they're slightly older. But with children, they'll come in with lots of abdominal pain, especially in the right lower quadrant where the ileocecal valve is. People might experience vomiting and urgency, and importantly, they'll probably have some sort of weight loss or systemic issues, which you wouldn't see in irritable bowel syndrome. They'll have perianal disease, so skin tags or ulcers, and extraintestinal features like arthritis or skin issues, which we'll go through. So what would you do for investigations? You'd give them, you'd take bloods, obviously, to get the CRP, which can increase with increased disease activity. Fecal calprotectin is a really good marker of inflammation. It's raised in D, but not in IBS, so you can rule out IBS. Stool microscopy and sensitivity. That's used to exclude infections. So we would send them off for colonoscopy, and they have very specific appearances on colonoscopy, such as the cobblestone appearance, and they'll have skip lesions, really deep lesions and ulcers. And you also give them small bowel enema, which is when they have some barium, and you give them the X-ray. And I'll show you the pictures of what it would look like on the next slide. And on histology, they'll have what we call transmural lesions, which is when the entire wall from inside to the outside is affected. So that's why you would get things like fistulas, because it might connect to the organ that's next to it. You'll also see goblet cells and granulomas. So this is the small bowel enema. You see this, what we call Cantor's string sign, which is these bits where they kind of turn into like strings. and rosestone ulcers, which you can see here. So how would we manage someone with Crohn's disease? You'd advise them to stop smoking because smoking makes it worse. To induce remission, you'd give them steroids because it's an inflammatory disease. And second line, you give them 5 ACE drugs, such as mesalazine, and that stands for aminosalicylic acid. If that doesn't work, you can add on azathioprine or mercaptopurine. Before you give them that, you need to assess their TPMT activity, which is just a blood test. So what that is, it's an enzyme that inactivates toxic byproducts of azathioprine metabolism. So if you don't have this enzyme, people tend to be prone to azathioprine toxicity. If that doesn't work, I think hospitals now quite like using infliximab, so the monoclonal antibodies. So if you've achieved remission, to maintain it, you'll keep them on azathioprine and mercaptopurine. And if second line, if that doesn't work, you use methotrexate, which is a DMARD. You might have heard for rheumatoid arthritis. And as a last resort, people will get surgery, and this is not curative. And if people get too much surgery, they can get, I think, what we call a short bowel syndrome, where they don't have enough food bowel content to process all their foods. And I think around 80% of patients with Crohn's will eventually get some sort of surgery. So next we have ulcerative colitis, which is also a chronic inflammatory GI disease, but this time is characterized by mucosal inflammation instead of transmural. Peak incidence of UC is in both people aged 15 to 25 and 55 to 65. So you get the younger people and the older people. So the inflammation always starts at the rectum, and it never spreads beyond the ileocecal valve. And the disease is also continuous, unlike Crohn's, which can have skip lesions. So how would they present? Unlike Crohn's, they'd have bloody diarrhea. They'll have urgency and tenesmus, and lower quadrant abdominal pain. Left lower quadrant. They might also experience systemic symptoms such as fever, malaise, anorexia, and weight loss, and usually that occurs when they have a flare-up of their UC. So there's a criteria that you can categorize how severe someone's UC is. So you can go from mild, which is when you have about 4 diarrheas a day, and there's no blood in their stools. Moderate, they might have some blood in their stools. They'll go to the toilet 4 to 6 times a day. And severe, there's very visible blood, and they'll have to go 6 or more times a day. Like Crohn's disease, CRP correlates with disease activity, and fecal calprotectin would be raised. And because there's a lot of bleeding going on, they might have anemia. As with Crohn's disease, you'd also give them take an MCNS to exclude any sort of infection. And again, colonoscopy is the investigation of choice. So this time you see a continuous inflammation, loss of haustral markings, and pseudopolyps. So the haustra is the colon, when the colon became segmented, if you can remember, like a abdominal X-ray. And in a histology, you'd see a lot of goblet cells, crypt abscesses, and inflammatory cells, mainly lymphocytes. So these are kind of buzzwords. If you see them, you think, UC, not Crohn's. In barium enemas, you'd see a lead pipe inflammation. which I'll show you in the next slide, and also thumb printing, which is a sign of bowel wall inflammation. In acute settings where they come in with a flare, you'd give them a chest x-ray / abdominal x-ray to exclude a toxic megacolon and any sort of perforation, which would appear as a pneumoperitoneum in an erect chest x-ray. Toxic megacolon is when the colon becomes really, really wide and it stops working due to the excess inflammation. CT is preferred over colonoscopy in acute settings, just because there's a risk of bowel perforation if they're having a acute flare-up. This is a lead pipe colon on the left here, and the thumb printing, if you can see like this little sticking out thing, and it's a sign of the inflammation of the bowel. Yeah, and here's the pseudopolyps colonoscopy. So to induce remission, if it's a mild to moderate disease and you go through the criteria that we've been through before, you give them mesalazine or any sort of ASA drugs. So first it will be topical, and then you add oral, and then you move on to corticosteroids. So proctitis means it's just a inflammation of the rectum, and then proctosigmoiditis is when you have inflammation of the rectum and the sigmoid colon. So these are just treatments that you have to remember. Usually it just goes from topical, mesalazine, and then oral, and then topical, oral corticosteroids. And importantly, if it's a severe colitis, you have to admit them to hospital and you give them IV steroids. So you don't use mesalazine. And if it's been 3 days and there's no improvement, then you add IV cyclosporin, or you consider surgery. So you probably refer them a little bit earlier if you're not seeing any improvements. Okay. And once you've managed to get them into remission, then you try and maintain this by, again, using, depending on where the flare-up is. So if it's proctitis and proctosigmoiditis, then you give them topical ASA or oral ASA and topical, or just oral. If it's extensive, if it goes beyond the left side, or it covers the whole of the left side of the colon, you give them oral mesalazine. And if it's following a really severe relapse, they've had to get IV steroids, or they've had 2 or more exacerbation in the past year, you give them oral azathioprine or oral mecaptopurin. And again, you have to remember to assess the TPMT activity. And then we also have surgical options for you. So that could be a pan-proctocolectomy with a permanent endoileostomy, or an ileal pouch anal anastomosis. So the first option, obviously, you'd end up with a stoma, and the second option, you'd have a stoma for a little while whilst anastomosis heals, and then you can not have a stoma after that. So IBD can show up with extraintestinal features. So this is also where there's a difference between irritable bowel syndrome. So this is an ulcer, I think, in the mouth, yeah. And you get anterior uveitis, and this is called pyoderma gangrenosum, and these are erythema nodosum. So you get the ulcer only in Crohn's disease. I think the others are seen across both UC and Crohn's. So yeah, So with Crohn's disease, you might get gallstones, fistulas. So you only see fistulas in Crohn's because it's transmural, and you get ulcers in the mouth. With both, you'll see eye issues like anterior uveitis, you get arthritis, clubbing, and the two skin conditions we just saw, and you might also get osteoporosis. With ulcerative colitis, you might have heard of primary sclerosing cholangitis, which is a disease of the biliary tract. And around 80% of the patients with PSC have ulcerative colitis, but not all the patients with ulcerative colitis will have PSC. That's a lot lower, only about 4%. And with this, it comes with increased risk of colon cancer and also cholangiocarcinoma. And yeah, importantly, it doesn't correlate with disease severity. So just because they have all of the above, okay, fistulas will probably be quite severe, but it doesn't necessarily mean that their Crohn's, their UC would be really, really bad if they have a very severe pyoderma gangrenosum, for example. Okay, next we move on to celiac disease. So it's an autoimmune disease caused by intolerance to gluten. So that's found in wheat, rye, and barley, which is obviously quite a lot in our usual diets. Bread, it's in beer. So how would they present? They'd come in with a chronic or intermittent diarrhea. Usually it smells very foul, it's bulky, and it's really difficult to flush down the toilet. And in young children, they might have failure to thrive, or the growth isn't sufficient. They might have nausea and vomiting. They'll be very fatigued, and there'll be signs of abdominal pain, cramping, or distension. And they might also have unexplained iron deficiency anemia on their blood tests. So when patients are suspected or have the diagnosis of celiac disease, you have to screen them for other autoimmune diseases, such as thyroid disease, dermatitis herpetiformis, and type 1 diabetes. And you also should screen their first degree relatives for celiac disease. So with dermatitis herpetiform, it looks like this, and it usually presents in places like the elbows and the knees. So when you investigate celiac disease, you have to tell your patient to reintroduce gluten in their diet for 6 weeks before you send them off to biopsy. And that's because you want to see what it looks like after they've eaten gluten. Obviously, if they haven't eaten gluten for 6 weeks, it won't look like, you won't be able to identify it, basically, because it won't have been damaged and it recovers. So you will get blood tests for tissue transglutaminase antibodies, so TTG and IgA. And you also should get, the reason why you get IgA, endomysial antibody, is because you need to look for IgA deficiencies. If they have IgA deficiencies, then you get a false negative for TTG. So with endoscopic intestinal biopsy, this is gold standard for diagnosis. You'll find what we call villus atrophies, crypthyperplasia, increase in intraepithelial lymphocytes, laminar propria with infiltration with lymphocytes, and this is what it'll look like. So on the right is a normal biopsy. So this on the left is a duodenal biopsy from a patient with celiac disease. So you can probably see this complete atrophy of the villi. On the right, you can see very prominent villi here. On the left, it's atrophied. The mucosa is very flattened. And there's crypt hyperplasia, if you can see like these hyperplasia. And there's also infiltration of inflammatory cells, if you can see in between here. Okay. So how will we manage it? You tell them to stop eating anything with gluten in it. So wheat, anything bread, pasta, pastry. There will be obviously a lot of gluten-free options nowadays. Rye, oats, but they can replace these carbs with rice, potatoes, and corn. So patients with celiac disease, they might have a functional hyposplenism, so you need to offer them the pneumococcal vaccine, which is repeated every 5 years. And influenza vaccines may also be offered. So with celiac disease, if you maintain a gluten-free diet, then you can pretty much not have any issues. But if they do continue, then they can have complications such as anemia, hypersplenism, osteoporosis, lactose intolerance, and a specific type of cancer called T-cell lymphoma of small intestine, and also experience subfertility. So it's really important for them to not have a gluten-free diet, and you have to explain that to the patient. So next we move on to irritable bowel syndrome. This is a condition that's obviously quite common to come across, but it's a diagnosis of exclusion. So you kind of need to do all the investigations and make sure it's not something else. So it's usually a pain that is relieved by defecation, or it's associated with altered bowel frequency or stool form. So with IBD and things, even if they go and defecate, they may still have that pain. And you need at least 2 of altered stool passage, like straining or urgency, bloating, symptoms made worse by eating, or passage of mucus in their poo. And the pain shouldn't be so severe that it wakes them up at night. And the red flags that indicates different sort of disease other than IBS is rectal bleeding, unexplained weight loss, which might indicate more towards IBD, or celiac disease, and any family history of bowel or ovarian cancer, and onset after 60 years of age. So you need to do fecal calprotectin, so that will be raised in IBD, but not IBS. Full blood count and ESR or CRP, which is also raised in IBD, but not IBS. Make sure there is no anemia, and do the celiac serologies, so the anti-TTGs and IgA. So the management is usually conservative. You need to advise them for dietary change and sort of help them cut out certain foods and see if it makes a difference. With IBS, there's what we call the low FODMAP diet, which basically means not to eat excess fructose, lactose, or very specific kinds of vegetables and things. And it's one of the diseases where too much fruit isn't recommended. So first line, you give them pain relief and something for any, depending on the symptoms. If it's constipation, you give them laxatives, and if it's diarrhea, you give them loperamide. And because they don't know they think it might be a neuro gut-brain axis kind of disease, second line, you give them a low-dose tricyclic antidepressants. And then third line, psychological interventions. So, yeah, so if you see these buzzwords, what do you think of? Foaming macrophages is, irritable bowel syndrome, no abnormalities, yeah. Laxative abuse, Yeah, you can see these pigment-laden macrophages. So this on the right is the colonoscopy, and it's called melanosis coli. It's not very pleasant. Whipple's disease, we have what's called foamy macrophage. This disease is caused by a gram-positive bacteria, and it causes malabsorption in the GI tract. So ulcerative colitis, as we've mentioned, pseudopolyps, goblet cell depletion, and cryptabscesses. Crohn's disease, yep, granulomas, increased goblet cells, celiac disease, villus atrophy, and cryptoplasia. Okay. So case 2, we've got a 62-year-old lady. We're complaining of feeling very bloated for the past 3 months and a reduced frequency of opening her bowels. Recently, she had noticed a small amount of blood in her stool. So this should be getting all your alarms going. So colorectal cancer, it's the 3rd commonest cancer in the UK and 2nd commonest cause of cancer deaths. So most cancers develop from adenomatous polyps, and the most common locations are rectal and then sigmoid cancers. So there's several risk factors. There's the ones you can't change, which is age, and if you're a male. But diets high in red meat and fat and poor in fiber also increases your chance of getting colorectal cancer. As with probably most cancers, a sedentary lifestyle, obesity, smoking, alcohol, and having IBD also increases the chance. And importantly, the hereditary syndromes, which we'll go through. So the features of colorectal cancer, as you'll probably expect, is blood in your stool, changes in your bowel habit, mass that can be felt in the stomach, unexplained weight loss, abdominal pain, tiredness, and any signs of bowel obstruction. So not passing wind, not passing feces, vomiting, etc. So right-sided colon cancer usually presents with weight loss, anemia, bleeding, and mass on the right quadrant, and it's typically more advanced at presentation. Whereas left colon cancer can come with colicky pain and rectal bleeding. I think colicky pain basically means when you eat, you get pain. Bowel obstruction, tenesmus. So tenesmus is the feeling like I think you finished pooing, but you feel like there's still more left. And a mass on the left side, early changes in bowel habit, and it's usually less advanced at presentation. So hereditary cancers, the most common is called HMPCC, and it's a dominant disease. It increases the chance of endometrial, ovarian, gastric, and breast cancer as well. So you can remember them as the female ones. And so you need biannual endoscopic surveillance. The next most common is FAP, familial adenomatous polyposis, and this is also autosomal dominant. And you get hundreds of polyps. So polyps is just the projecting growth of tissue from the surface. So if they have FAP, you need to give them prophylactic colectomy. Otherwise, it will 100% lead to a colorectal cancer. Next one is, I never know how to say this, Peutz-Jeghers syndrome, which is also dominant, and it presents with hyperpigmentation. So like in this picture, on their lips, freckles, genitals. You get multiple hematomous polyps. What this means is it's a benign tumor-like malformation made up of abnormal mixture of cells and tissues, but these cells are like non-cancerous cells. And with this, you need pan-endoscopic surveillance every 3 years. So with HMPCC, it's every 2, it's biannual. Yeah, so most colorectal cancers are sporadic, but the 5%, rest of them are made up of mainly these hereditary syndromes. So the screening process is really important. You need to remember these really well. So in England, with all patients aged 60 to 75, you have biannual fecal immunochemical test. So the fit stool test, which you'll be sent probably in the post. So patients with the positive results are referred for the 2-week wait pathway for a colonoscopy. What the fit test looks for is any blood in the stool that they'll detect anything that you can't see with your eyes as well. So other 2-week wait criteria for colonoscopy include if you're 40 and over and you experience unexplained weight loss and abdominal pain, 50 and over with rectal bleeding, unexplained. So if you obviously have like a long history of, let's say, piles and it's always bleeding, that might be different. If you're 60 and over with either iron deficiency anemia or changes in the bowel habit. So that could be all sorts of things. So with investigations, you'd send them to colonoscopy, which usually you take a biopsy, and also a CT cap, which is a CT chest, abdomen, and pelvis. And pelvic MRIs are preferred over CTs in rectal disease because it just shows up better. So CEA, it's not used as a diagnostic tool, but it can be used to monitor therapeutic response. So it should go down with good therapeutic response. So the Duke classification was used, but I think now TNM staging is more common. So yeah. So management, this is where we send them off to surgery or refer them for GI surgery. So depending on the cancer site, the type of resection will be different. So if you have any cancers around here, cecal, ascending, or proximal transverse colon, then you'd have a right hemicolectomy. So you remove all of this area. You have an ileocolic anastomosis, which means your ileum will be connected to the colon, somewhere around. And then if it's a distal transverse or descending colon cancer, so anywhere around here, you'd have a left hemicolectomy, get rid of all of this, and then connect this bit of colon with this bit of colon. If it's a sigmoid colon cancer around here, you have a high anterior resection, where you get rid of the sigmoid colon and the rectum and leave the anus. Upper rectum, you'd also have an anterior resection, leave the anus. Lower rectum, now this time a lower anterior resection, and then if it's a cancer in the anal verge, you do what we call an abdominal perineal resection, where they get rid of including the anus. So the next slide is basically that, explaining diagrams. So hemicolectomy, get rid of that. The yellow is basically what they resect. Cool. And now I'm going to hand over to, Martha.
Yeah, I can share my screen and you can.
Yeah, that'll be perfect. Thank you.
Cool. No worries. Cool, can you see that?
Yeah.
Perfect. Wait, can you still see that, or do you see this presentation mode?
I see the presentation mode.
Oh, okay. All right. You know what? Okay, let's. I might just do it like this because I've got several screens up.
Yeah.
Okay, cool. So Shall I pop my camera on as well? Cool. So I'll be talking first a little bit about stomas, and recognizing these are a really useful skill when you're actually on the ward and something that can very feasibly come up in your exam. So I'd highly recommend getting familiar with them and recognizing the different types. So the first thing you can differentiate is whether it's an ileostomy or a colostomy, and kind of in the name, an ileostomy involves the ileum, whereas a colostomy involves the colon. So let's first talk about ileostomies, because that's what they have on the slide here. So ileostomies are typically located on the right, whereas the colostomy would be on the left. So ileostomy is going to be on the right iliac fossa. And when you have a loop, that means you literally take a loop of bowel and bring that whole loop to the surface of the skin. And you can kind of think logically as to why you might do this. Typically, this is not going to be permanent. This is because you want to kind of take the section of bowel below this loop out of function temporarily, because you want to let it heal or let it recover from recent bout of infection, or maybe you've just had like another surgery down there and you want it to heal first before you kind of have all this digested food going through it. So that's what this might be used for. A loop ileostomy is very common, and yeah, so most commonly, if someone has a loop ileostomy, it's likely to indicate they've had an anterior resection. So what this is a removal of the rectum and sigmoid colon. And in this case, there's a new anastomosis that's been formed below the loop, and you create the loop so that it can heal. So moving on, the other kind of ileostomy you can have is an end ileostomy. Again, in the name, instead of bringing a loop of bowel up to the skin, we now have only one end. So there's only one lumen. And in this case, kind of, again, you can think about it logically, it's usually following a complete excision of the colon instead, or where like you've not really planned doing an anastomosis, so this is what you've ended up with. This is more likely to be permanent, but it can still be reversed, though a bit less commonly. An important thing to note about ileostomies versus colostomies is that these tend to be spouted, so there's a bit more of bowel kind of protruding, or at least a bit more of the ileum protruding out of the skin. And again, you can think about this logically in terms of the fact that the contents of the ileum are more likely to be liquid and more likely to be irritating to the skin. So you don't want that bowel to be completely flush to the skin and have all of this kind of irritate the skin constantly, if that makes sense. So moving on to colostomies. Loop colostomies are a bit more rare. You don't really see them very often. The reasons why you might do it are kind of twofold. The first thing is diversion. So you want to keep feces out of a certain part of the colon, then you might do this. Another reason is decompression. So usually from a source of kind of bowel obstruction. And if you want to like give yourself some time to remove that source of obstruction, you might do a loop colostomy. And again, just like loop ileostomies, they're temporary. So they're literally created because they're going to be reversed at a later date. And different to the ileostomies, these are going to be flush to the skin completely. And that's because the contents of the colon are a little bit more solid and a bit more formed. So it doesn't really matter if it like touches the skin as much because it's not as irritating. Cool. So end colostomy, sorry, these you will see far more frequently. And these can be both permanent or temporary. And this is when you have one lumen again, which is flush to the surface, and like feces or waste material is then collected through that. So if it's permanent, it's usually a result of the abdominal perineal resection. So this is a removal of the entire rectum and anus. And in that case, you're kind of either permanently or temporarily left with all your waste kind of coming out of the stoma and into your into the collection bag. Sometimes, like it says here, this is a result of a Hartmann's procedure, but sometimes they split the Hartmann's procedure into two parts. So in that case, the stoma can potentially be reversed. Yeah, and an important thing to know about the Hartmann's, we'll talk a little bit more about this later, but it's not usually something nowadays that is planned. It's usually something that's done in an emergency. So oftentimes someone might end up with an end colostomy if they have like perforation or something where they've unexpectedly had to remove a big chunk of bowel, basically, and it's not really safe to form anastomoses at that point, so you end up with an end colostomy. Cool. So I've touched on this briefly before, but again, key factors to differentiate an ileostomy and colostomy. First thing is location. So ileostomies are almost always in the right iliac fossa. Colostomies, typically, if it's in an exam question, it's going to be on the left, but it varies. You can see very clearly by the appearance of the actual kind of bowels, whether it's an ileostomy or colostomy, because the ileostomy is spouted. There's quite a lot of it, like, actually protruding from the skin, whereas a colostomy is flush. So if we look at this photo here, this is an example of an ileostomy, because we can see some of that bowel kind of spattered out. I know it's not the clearest. And like I mentioned earlier, the output in the bag is going to be liquid in the ileostomy and solid in the colostomy. So if, say, you're in an OSCE, you are asked to do an examination of someone's stoma, even though I think it's unlikely to come up, it is always helpful to comment on the contents inside the bag, if there are any, and how well formed it is. Cool. So let's move on. So let's talk about this case. A young man who arrives in A&E, and he's got pain in the lower abdomen, feeling generally unwell when he woke up this morning. At this point, this is very vague. There are lots of questions we might want to ask, and our differentials might include anything from gastroenteritis, appendicitis, maybe IBS, IBD, even, you know, something like diabetic ketoacidosis, you know, that presents with abdo pain. You need to ask a lot more questions about his history. And in this case, they've not given any of that. But I think what they're trying to show is this is kind of a quintessential case of kind of acute onset lower abdo pain in a young person. More often than not, it's going to be acute appendicitis. So I'm sure most of you will probably already know what the appendix is. This is this kind of like small tubular structure on the end of your cecum. And appendicitis basically happens when you've got inflammation of this. And the kind of etiology or pathology of how this happens is usually you get something that causes obstruction in your appendix. This can be a fecalith, as it says here, which is basically a lump of really hard poo. And it doesn't necessarily have to be that. It can be a foreign body, it can be fibrous tissue, just something that causes obstruction in the appendix, and then it causes this kind of bacterial multiplication and potentially like damaging the tissue, causing all this inflammation and leading to potentially some tissue necrosis and, you know, from ischemia or even, you know, perforation. So potentially quite bad. And classically, in an examination, you'll have this periumbilical pain, so kind of in the center of the abdomen, and it migrates to right iliac fossa. It also presents with anorexia, which I'm just going to remind you, in the case of gastro, refers to, you know, having a loss of appetite, and it does not refer to anorexia nervosa. That's something separate completely, but this is just the terminology used. Anyways, so abdominal pain, anorexia, mild fever, nausea and vomiting, and sorry, let's go back. There are a couple key signs you might be asked about when you're on the wards or asked about in the exams, and this is Rovsing sign, the psoas sign, and they've not mentioned it here, but there's also the obturator sign. So Rovsing sign is when you palpate the left iliac fossa, and it causes pain in the right iliac fossa. Psoas sign, you don't really do this, to be honest, but it's pain when you like passively extend the right thigh. And then the obturator sign is pain with passive internal rotation of the hip. Again, these aren't really things that people do that often on the ward, but it's useful to know for exams. Yeah, and obviously, as it says here, always if there's guarding all over the stomach and there's tenderness, then at that point you might suspect perforation and peritonitis. And that's kind of a common theme with everything, with GI things. Cool. So diagnosing acute appendicitis. So first of all, someone comes in, they're quite young and they've got lower abdominal pain. If they're a woman, it's a little bit it's not the nicest thing to say, but one of the doctors told us this, is if a woman of childbearing age comes with abdo pain, the first thing in your head should be like, are they pregnant? And first thing you do in an exam in real life is do a pregnancy test, because you immediately want to rule out things like ectopic pregnancies, which is an emergency and you have to deal with that. And also you have things like pelvic inflammatory disease and all these other gynecological conditions which might be present and are very relevant as a differential. So always want to kind of think about that as well. So that's why that's relevant. And as this is an infection, as you might expect, you get raised inflammatory markers, you can do a urine analysis, and if you really want, you can do an ultrasound, but oftentimes this is a clinical diagnosis. Yeah. And management, usually just removing the appendix, so an appendectomy, and you can give prophylactic IV antibiotics. Just a useful thing to help you remember the fact that like gynecological conditions present very similarly to this is one of the surgeons told us last year that a lot more females have their appendixes removed than males, just because, you know, so many pelvic and gynecological diseases present so similarly, and because it's often clinical diagnosis, they just have it removed. So just an interesting fact for you guys. Cool. Here's just a kind of image of this big swollen inflamed appendix and how you might see it in laparoscopic surgery. Cool. All right, next, yeah, another case. So this time it's an older gentleman, a 63-year-old, and he's presented at A&E with a sharp pain in his abdomen. This was sudden in onset, and he's vomited twice since the onset and has unusual constipation. So this is another quintessential case presentation. And there are a couple of things here that kind of scream out what the diagnosis is to you. For me, those things would be the vomiting and the age and also the constipation. So we'll kind of go into that a bit more. And it's small bowel obstruction. So what it is kind of in the name already. In this case, we're talking about a mechanical obstruction, so something physically, you know, obstructing the bowel. And by far and by large, the most common cause of this is adhesions. And what these are, these kind of bands of scar tissue that form in your between your intestines and the other organs in your abdomen generally after surgery. So any kind of past history of abdominal surgery puts you at massively increased risk of having SBO. And why does that lead to SBO? Well, because if you imagine like these extra kind of adhesions between your intestines and all these other things, that's way more likely to kind of just twist and pull and compress the intestines in this way that can cause obstruction. So key features that define kind of, well, the presenting features of SBO in an exam setting, at least. The real life, I guess people can present differently, but typically the easiest way in an exam question to differentiate small bowel obstruction from large bowel obstruction is that there is a lot more kind of nausea and vomiting. Like there's a lot of vomiting with small bowel obstruction. And kind of just like large bowel obstruction, you'll get a lot of abdo distension, you'll get a lot of abdo pain, and you'll get tinkling bowel sounds. I guess in large bowel it might be empty, no bowel sound, sorry. But yeah, for me, the key kind of defining feature in an exam question that makes you think small bowel obstruction as opposed to large is the nausea and vomiting. So investigations, the first thing you'd want to do is a X-ray of your abdomen, and then you'll get distended small bowel loops. If you've had any radiology teaching, you might know that the kind of definition for what is distended with the small bowel is anything that's over 3 centimeters. And we'll talk a little bit about how you tell whether the bowel you're seeing is small bowel or large bowel in a second. But yeah, you do an abdominal X-ray first, and then you might do some bloods. You might do a chest X-ray as well if you're suspecting perforation or pneumoperitoneum. And sometimes you can do a CT as well, but I think this is a bit less common. So management is typically supportive and conservative at first. You do what we call a drip and suck. So you give them a drip, so IV fluids, and you suck. And in that case, that means putting an NG tube in and making them nil by mouth. So if they really don't improve in a couple of days, you would then consider surgery. But in the context of your exams, it would mainly be, you know, conservative. And of course, you can always help them manage their symptoms and give them pain relief and also antiemetics. So that's kind of the mainstay of treatment with a small bowel obstruction. Cool. So like I said earlier, let's talk a little bit about how you would distinguish small from large bowel and kind of the key things you look at in an abdominal X-ray. So just looking at this, obviously we've just talked about small bowel obstruction, so that's what this is. But the way we can tell that there's a small bowel is A, it's centrally located. From your knowledge of anatomy, hopefully you know that the large bowel's on the outside, small bowel's central, it's like centrally located. And another defining feature is that they've got what we call valvulae conniventes. These are these kind of lines that stretch across the lumen of the small bowel, whereas in large bowel, they don't stretch it the entire way across, and those are called haustra. We'll see some of those later. So valvulae conniventes, haustra. If you're asked to look at an abdominal X-ray, always you'll get marks for commenting on both of these. I know you're not exactly going to whip out a ruler and measure this, but I think this is quite obviously distended and increased in diameter, and we'll see some of the large bowel later. That's even more obvious because, you know, that's even bigger. So, all right, moving on. Oh, more small bowel obstruction. Cool. So what this is showing is here we've got a chest X-ray, erect chest X-ray, and here we see pneumoperitoneum. So that's air where it shouldn't be, below the diaphragm. And it's important to distinguish whether it's on the right side or the left side. So this is the right, this is the left. Here, there is air here too, but that is inside the stomach. It's called the gastric bubble. So that's completely fine. But when you see air on this side, that is not fine. Especially when you see it's kind of got this this kind of crescent sign. So it's got like the completely flat line below. That's kind of alarm bells for pneumoperitoneum. Next, here on the right, we've got what's called Wriggler's sign or double-walled sign. And it's kind of, it's quite subtle if you're not kind of looking out for it. It's really easy to miss unless like you have it in your head, I'm going to look for this. But notice here how you can see both the inside wall and the outside wall of the bowels. And if you think about that logically, the only reason why you see it is because there's air on both the inside and the outside. And that should not be the case. So when you can see both sides of the wall, that's, again, alarm bells. There has been perforation and there's air in the abdomen. Cool. So moving on. Let's talk a little bit about hernias. So you'll see the word hernia used quite often in medicine. It basically just means like a kind of protrusion or bulge, as it says on the slide, I'm sure you can read it, of an organ or like a part of your viscera that like kind of protrudes through a tissue layer or a body wall that normally contains it. So it ends up somewhere that it's not supposed to be. And just a helpful thing for you guys to remember this, or at least don't make the same mistake I did, is because hernia is such a commonly used phrase in medicine. Don't make assumptions. Obviously, I guess the most common thing you'd see it in is like abdominal hernias, but remember you also have herniated discs and you can have brain herniation. So I once had a patient told me they have a hernia and their English wasn't very good, and I automatically thought, oh, you've got an abdominal hernia, but turns out they just had a herniated disc. So make sure you kind of, when someone tells you they have a hernia or they've thrown around the word hernia, don't automatically jump to this because there are other things that can herniate. But anyways, going back to our abdo hernias, there are several ways we want to classify them before we go into the actual anatomy of where it's located. So first thing is whether or not we can push it back in. If we can, then it's reducible. If it can't, then it's irreducible. And we're a bit more concerned about the irreducible ones, because if they're irreducible, that means they're either incarcerated or strangulated. So incarcerated just means that it's stuck kind of in its position due to adhesions, or like the neck is too small for it to be pushed back in. And when it's strangulated, this is an emergency. We are extremely concerned because the hernia is cutting off blood supply to the rest of the intestines, and this, like as you probably know, can lead to ischemia, can lead to necrosis, can lead to all kinds of really nasty things. So if someone's got a strangulated hernia, this is emergency surgery ASAP. Yeah, and yeah, here it says obstruction as well, so it just means that there are bowel contents inside the hernia that can't move through, so that's also pretty bad. There are two main types of abdominal hernias that you will see, and you'll probably come across in your exams most frequently. There are obviously many other types, but these two are the most common, so we'll talk about those. So the first one is femoral hernia. It's called femoral hernia just because this section of bowel has herniated into the femoral canal. You can go look into the anatomy of what makes up the borders of the femoral canal, and that'll probably get you extra brownie points if you end up in surgery scrubbed into one of these. But key things to remember with the femoral hernia is that it mainly affects women, kind of middle, older age, and in your typical past med or exam question, you'll be asked to differentiate a femoral from an inguinal hernia. So it's located inferolateral to the pubic tubercle. And femoral hernias are far more likely to strangulate. So treating them is quite urgent. Yeah, and those are really the key things you need to know about it. Yeah. Cool. So like I said earlier, strangulation is far more likely to happen in a femoral hernia, and you need to recognize like the signs of strangulation. So, you know, there are obvious ones like pain, fever, increase in the size, and if it's strangulated, it's going to be irreducible. And like I mentioned earlier, you have this kind of ischemia, potentially leading to necrosis, potentially leading to perforation, and in that case, then you're going to have things like you're going to have signs of peritonism as well. So like they might start kind of being septic, and they might have like guarding and tenderness all over the abdomen. So those are things to look out for. This warrants immediate surgery. Yeah. Cool. So moving on, inguinal hernias. This is more common overall, and it's most common in men, and especially like men who might do like strenuous labor, like lifting a lot of really heavy things, and also kind of anything that increases the pressure on the bowels, like things like pregnancy, and make them more likely to herniate, put people at a higher risk of getting an inguinal hernia. And just like with femoral hernia, inguinal just refers to the location of the hernia itself. In this case, it herniates into the inguinal canal. We'll talk a little bit more about the anatomy of that later. But again, it's worthwhile to go back and revise your anatomy of what forms the borders on each side and on the back of the inguinal canal. Cool. So this, as opposed to the femoral hernia, is located medial and superior to the pubic tubercle. You'll find when you're doing past med that is the key phrase you need to know in terms of differentiating the two. With this, they can either be reducible or irreducible, like we mentioned earlier, and they can be direct or indirect. Let's talk a little bit about the anatomy of that, actually. So here we have an image of an indirect hernia. I always thought the naming of it is a little bit like not intuitive, and we'll explain why here. Because the indirect hernia actually enters the inguinal canal where things are supposed to enter. It enters in the deep inguinal ring, and in this case, an easy way I think to remember it is that this is far more likely to be congenital, and it's far more likely to be seen in young males because it's from like a patent processus vaginalis, and in this case, it can actually descend to the scrotum and has a high risk of strangulation. So on past med, if you see like someone's got a hernia that's in the scrotum, and young boy, it's more likely to be an indirect inguinal hernia, essentially. Whereas with a direct inguinal hernia, this protrudes directly through the back wall of the inguinal canal, and we call this the Hesselbach's triangle, the place where it protrudes. So I guess in that sense, it's protruding directly rather than through the opening of the canal, which I guess is why it's called direct. And the demographic for a direct inguinal hernia is typically like an elderly man, as opposed to the kind of congenital picture we might see with an indirect inguinal hernia. So the way you can kind of differentiate between a direct and indirect hernia on a patient is if you locate the deep inguinal ring. This is halfway between the ASIS, so the anterior superior iliac spine, and the pubic tubercle. And you can first locate that and then push the hernia back in. And and then you can press on the deep inguinal ring and ask them to cough. And if it reappears, then it's direct. If it doesn't reappear, it's indirect, because you've kind of, your other hand is pressing on where the hernia is coming out from, if that makes sense. Realistically, in actual clinical practice, it's not so kind of clear cut to differentiate whether a hernia is femoral or inguinal. Like last year, I remember speaking to some surgeons where they were like, yeah, realistically, sometimes you only really tell when you actually cut the patient open and you see where it is located, and then you know for sure this is, you know, inguinal, this is femoral. But both of them are indicated for management pretty much like as soon as we know about it, although some are more urgent than others. So pretty much management is always with a hernia repair, and this is a mesh repair. Let's go back. Yeah, so yeah, you can see here it's repair with like prosthetic mesh, and if it's recurrent, you're more likely to do it laparoscopically. All right. So now moving on into large bowel obstruction. As opposed to small bowel, the most common cause of this is with a tumor. So the kind of demographic you would see large bowel obstruction again kind of changes to fit that, to be people who are more likely to get tumors in their large bowel, so slightly older demographic. Another common cause would be volvulus. We'll talk about what that is later, and also diverticular disease, both of which we'll discuss. So the features of this, you can kind of think through logically. If your large bowel is obstructed, you're going to get complete, absolute constipation. And what I mean by that is not just you're not passing stool, but also you're not passing wind. So like you're not passing flatus. This is an extremely crucial question to ask patients, because, you know, just not passing stool might not mean anything, but if they're not passing anything at all and they've got a distended abdomen and they've got abdominal pain, this is kind of alarm bells for large bowel obstruction. You do get some nausea and vomiting, but it's far less common than it would be in small bowel obstruction. So I wouldn't really pay too much attention to that. And last of all, just like everything else we've discussed pretty much, if there's perforation, you're going to see signs of peritonism. They might start being septic, etc. So just like small bowel obstruction, the first thing you would do is have an abdo X-ray done. And like the slide earlier said, it's considered dilated if the large bowel is over 6 centimeters and if the cecum is over 9 centimeters. And trust me, when you see it, it's usually quite obviously distended, especially the ones you'll be asked about in your exam at least. Yeah, and management, it obviously depends on the case, but you would still try the drip and suck method just like you would small bowel obstruction. But by large, like, you are far more likely to end up having surgery if you have large bowel obstruction compared to small bowel. Just, it says here 75%. Like, a lot of the time, you know, you'll find textbooks which will just say management for large bowel obstruction is surgery, because so often they end up requiring surgery at the end of the day. So here we can see quite obviously a very distended large bowel. Going back to what we were talking about earlier with the haustra, you can kind of see that here. These, compared to the valvulae coniventes earlier, are quite distinct in appearance. And yeah, it's grossly distended and kind of peripherally located. So that is the distinguishing feature for large bowel obstruction. Cool. So volvulus is something that can cause large bowel obstruction. And this is when you get this abnormal twisting of a section of your colon, and then it compromises blood flow and causes obstruction. And this is a big emergency. It requires urgent kind of detorsion of this twisted bowel segment. And there's several ways you can do that depending on where it's located. If you remember your different sections of colon, the most common areas that the volvulus is likely to happen is your sigmoid colon and in the cecum. So with a sigmoid volvulus, because this is kind of near the rectum and the anus, we can actually treat this with what's called a rigid sigmoidoscopy and rectal tube insertion. And yeah, basically that if you insert this through the anus, this will kind of detangle, so to speak, the colon, the sigmoid colon. Whereas the cecum is a little bit harder to reach because it's basically the complete opposite end of your colon. So usually people end up with surgery and often with a right hemicolectomy. So here you have a very useful little table kind of distinguishing what populations where you might see cecal or sigmoid volvulus. You're much more likely to see sigmoid volvulus in older patients, whereas with cecal, you can see them in all ages and are more likely to be a result of pregnancy, not a result of, but like risk factors would be adhesions in pregnancy. And more x-rays. So the typical kind of sign of a volvulus, people will say, is a coffee bean sign. We don't see that here, but we see that here. So this is a big coffee bean sign of a sigmoid volvulus. And in a cecal volvulus, you don't see that. But you can see this kind of gross dilation, and it's more on the right side. So that's kind of the way you would tell a cecal from a sigmoid volvulus from an x-ray. Yeah. If anyone has any questions, by the way, feel free to interrupt, but okay, moving on. So now talking about diverticular and diverticular disease. First things first, it's crucial to kind of differentiate each of these things that have been listed here with definitions. So having diverticular in itself isn't necessarily, you know, a bad thing. It can very much and most often is asymptomatic. So diverticular in themselves are outpouchings of, you know, the colon wall, like the colonic mucosa, sorry, through the muscular wall of the colon. And this most commonly affects the sigmoid colon. This often is asymptomatic. And you can have diverticulosis, which is where you have more than one diverticula. And where this starts becoming quite concerning is when you develop diverticular disease, which is when these actually start to give symptoms. And diverticulitis is when you have infection of these. So really, really crucial kind of distinctions between each of these things. That's useful to bear in mind. Cool. So let's talk about diverticular disease. This, one of the surgeons told us last year, I don't know how accurate it is, but I guess a useful way to remember is you can think of it as like the old person version of appendicitis, and it affects the opposite side of your abdomen. It's not really accurate, but it can help you remember, because if we think back to appendicitis, that affects your right side, whereas diverticulitis, because we already said usually affects the sigmoid colon, usually affects your left side. So you'll get slightly older patients normally presenting with left lower quadrant abdominal pain and often some rectal bleeding and constipation. So those are your key presenting features, and investigations, it already says here, you would want to do a colonoscopy. With diverticular, oftentimes, like I mentioned before, they're asymptomatic, and in that case, you just leave them. For diverticular disease, you typically try supportive and conservative management first. So things like changing their diet, having more fiber, having more water. You might give them some laxatives and also give analgesia. But typically, you don't really consider surgery unless it's really severe and recurrent. Then you might have like an elective colectomy, but not unless it's really severe, essentially. Whereas diverticulitis is a little bit different because that is an infection. So this is going to be far more severe pain typically. And they're also going to have signs of infection. So like things like fever. And if there's perforation, just like everything else, you're going to get signs of peritonism. And you want to treat this with antibiotics. You can kind of see the stepwise approach you would take with management here. And at the very top end of the spectrum, where it's really complicated, you might end up with a Hartmann's procedure, which typically you only do when you get like perforation and it's like an emergency scenario. Yeah, it mentions here that colonoscopy should be avoided as risk of perforation. And this is often the case with like a lot of the other conditions we've talked about today. Whenever there's a risk of perforation, you try to avoid a colonoscopy. Even with people like with ulcerative colitis, if it's really severe and you want to avoid kind of irritating the whole colon, you don't really do a colonoscopy. Yeah, just a useful thing to remember. A common complication of diverticulitis that's worthwhile mentioning is diverticular abscesses. I think there's a little bit on it later, but we'll get to that in a bit. So we mentioned this several times already in this presentation, but there's a slide for it in itself, the Hartmann's procedure. Nowadays, it's not so commonly done as a planned thing, but you might end up having one in an emergency setting, like I said, when you have perforation of your bowel. What it is a proctosigmoidectomy, so resection of the rectosigmoid colon, and then you end up with this down here, this anorectal stump, which is closed, and then you have this end colostomy here. This can be temporary or it can be permanent. If it's temporary, then you will at some point try to kind of anastomose these two. But I don't think that's super common, to be honest. I'm not entirely sure, but I don't think that's particularly common. Useful hint, if you are told to examine a patient with a stoma, is to also check for the presence of an anus, because if they don't have one, then they've probably had a Hartmann's and an end colostomy. Yeah, so if end colostomy, no anus, you're thinking they've had a Hartmann's, basically. So nowadays, the main indications for Hartmann's would be peritonitis caused by perforation, or if a safe anastomosis just is not possible, or if someone's got really, really complicated diverticulitis, then you might be thinking about one of these. But yeah, not super commonly done. Like I said before, diverticular abscesses, a common complication of diverticulitis, and I wouldn't stress too much about this classification. I've never seen this come up anywhere, but I guess useful to know, just, as a future doctor. And it says down here that stage 1B and 2 can be drained by interventional radiology. And you can see here, peritonitis, you're already thinking emergency surgery. So I'm hoping at this point, this should be intuitive, that when someone's got peritonitis, like you're thinking there's literally pus in the abdomen or poo in the abdomen, this person needs surgery. They're probably quite unwell. So hopefully that should be relatively intuitive. Cool. So moving on, I think I'm passing on to Nora, who's going to tell us a little bit about intestinal ischemia.
Yes, thank you very much for that fantastic presentation. I hope you can see my slides. Sorry, I'm just finding it started from the beginning for some reason. So, can you see that?
Yeah, I can. Yeah.
Perfect. Great. So I'll head straight on to intestinal ischemia. Sorry. So intestinal ischemia is basically when there's a reduction in the blood flow of the mesenteric vessels. So mesenteric vessels are the blood vessels that supply the gut, basically. So the structure of the gut that can be affected in mesenteric ischemia is basically either the small intestine, and this is called, intestinal ischemia. So intestinal ischemia is when there's a reduction in blood flow, and the intestinal ischemia can either affect the small intestine, and that's mesenteric ischemia, or the large intestine, and that's called ischemic colitis. Mesenteric ischemia is further classified into either acute mesenteric ischemia or chronic mesenteric ischemia. And this is important to differentiate because they present very differently as well. Another name for chronic mesenteric ischemia is angina abdominalis. So acute ischemia is normally caused by either for example, a clot that's blocking the blood flow, or an embolus or a thrombus blocking the blood flow. But there are sometimes non-occlusive causes, so no clots are present, but there's hypoperfusion. If, for example, the patient has heart failure, or if they are on vasoconstrictors, or they have dialysis, they can have hypoperfusion, and that can present with mesenteric ischemia. There are risk factors that can predispose to mesenteric ischemia. I think these make sense. So when you age, you get more atherosclerosis in all the vessels, including the mesenteric vessels, the vessels supplying the intestines. So of course, you can develop ischemia. If you have atrial fibrillation, you have a higher propensity for clotting. So of course, so other causes of emboli, so endocarditis, malignancy, you're hypercoagulable, so you're more likely to develop clots. CVD risk factors, of course. And then again, if the patient presents in a young age, then it's more likely to be causes like cocaine, where there's hypoperfusion because of vasoconstriction of the vessels. So diagnosis is a CT angiography to make sure to see how the blood is flowing through those vessels. So the features of acute intestinal ischemia is sudden onset, severe, and out of proportion pain. So pain so you see the abdomen, it doesn't look necessarily grossly distended. So there's nothing really that makes you suspect anything. But when you touch the abdomen, it's really, really painful. Then you would suspect an acute ischemia. And then rectal bleeding, diarrhea. In more chronic ischemia, you develop lactic acidosis as well, because, of course, you have, tissue ischemia over time. That can also, of course, develop in acute ischemia, but it's more, I think from what I understand, in chronic ischemia, lactic acidosis and a raised lactate is more indicative that there's chronic ischemia, but of course, in acute ischemia, it can also happen. So in acute mesenteric ischemia, there's an embolism that has caused an occlusion in the arterial supply. So of course, there's a history, for example, of AF that's very typical in acute mesenteric ischemia. Treatment is immediate laparotomy, and that is especially the case if there is peritonitis or sepsis. In chronic mesenteric ischemia, it presents very differently to acute mesenteric ischemia. So you have more intestinal angina. So the patients will often present with colicky pain after eating, for example, weight loss. And then when you listen to the blood vessels, you can listen to, it sounds like turbulent flow. In ischemic colitis, there is acute but transient compromise of the large bowel. So the most likely blood vessels affected in ischemic colitis are watershed areas. And these are areas in the bowel where so imagine the bowel is a continuous tube. The blood, the supply to one part of the tube and another part of the tube may be from two different arteries. And between those two arteries are the watershed areas. So those areas have less vascularization, there's less blood flow going to those areas. So there's more likelihood of developing ischemic colitis in this area. On abdominal x-ray, you'll find a thumbprinting sign, and management is usually supportive unless there is, perforation or peritonitis. That was just showing the thumbprint sign. Okay, so again, this is just to show that intestinal ischemia is caused by blockage of one of these vessels. So here we have a case. Hugo is a 58-year-old man who complains with bleeding from back passage when opening his bowels. And this is a typical presentation of hemorrhoids. So hemorrhoids is when there is a swelling in the anal cushions, so dilation of the anal cushions. These anal cushions are specialized tissues that make sure that your sphincters work properly. So so you have the internal and external anal sphincters to make sure that there's no poop going out of your rectum without you wanting it to get out. And these cushions make sure that the sphincters stay closed. So of course, one symptom of hemorrhoids can be incontinence. So if there is a lot of damage to these cushions, they can become inflamed, and that's what hemorrhoids are. These hemorrhoids are found in the 3, 7, and 11 o'clock positions, as as labeled here on this diagram. And what's important to note about hemorrhoids is that the history will normally present with painless rectal bleeding. So this is very important because it helps us differentiate between another condition, which I'll mention later. So painless rectal bleeding, the bleeding is bright red. So that's hematochesia, that's lower GI bleeding. Melena, as you might know, is upper GI bleeding. That's the dark, smelly stool, dark red blood is in the stool, that's upper GI. Fresh blood is hematochesia, that's lower GI. So in hemorrhoid, you'll get this bright red blood. It's not mixed in with the poo though. It's that's important to ask as well. So the patients won't complain of pain necessarily when passing the stool. More than anything, they'll complain of this bright red blood, but also itching in the anal area, so pruritus. Pain can happen if there's stasis of blood flow in these anal cushions. So the blood vessels expand and expand and expand, and over time it can cause the blood to pool in the cushions, and that can cause pain. And then, of course, you can get incontinence because these cushions control these sphincters. So if they become defective, then you can get incontinence. So there's different types of hemorrhoids. So first of all, I should mention there's two main types of hemorrhoids, external hemorrhoids and internal hemorrhoids. It's not that important for you to know, just know that external hemorrhoids originate below the dentate line, and then internal hemorrhoids originate above the dentate line. The dentate line is basically where the gut transitions into like skin tissue. So if you think about it, the rectum is a continuation of your colon, and then after the rectum you have the anus and then skin. So the transition between the tissue of the gut and the tissue of the skin, those epithelial cells, is the dentate line. So the internal hemorrhoids can be grade 1, where there's no prolapse of the cushions. Grade 2, when there's prolapse of the cushions, but they go back by their own, they spontaneously go back. Grade 3 is when the cushions prolapse, and they won't go back by themselves. You have to push them back up. And then grade 4 is when the cushions prolapse and you can't reduce it. You can't put it back up. So with hemorrhoids, there's a specific way to manage them. So first of all, you want to do a PR exam. Then you can do a proctoscopy. A proctoscope is just a hollow tube that allows you to visualize the anal canal. And then you can also do a sigmoidoscopy if you want to identify some sort of cause for the hemorrhoids and any pathology. But yeah, in young people, just a digital rectal exam is sufficient. Management is symptomatic relief. So conservatively, you want to prevent and treat constipation. So you want to increase their fiber, tell them to drink lots of fluids, use laxatives if they have to, and avoid straining. So give them good advice on what to do when they're emptying their bowels. You can give them topical corticosteroids if you want to reduce their swelling. If they have grade 2 or 3, so those are the ones where they prolapse, then you can consider rubber ligation, sclerotherapy, or photocoagulation. And then if they have grade 4, so the ones that are non-reducible, then you want to remove them. So a hemorrhoidectomy, surgical hemorrhoidectomy. Thrombosed hemorrhoids was what I mentioned before. If there's blood pooling in the hemorrhoids, it can cause a lot of pain, and the hemorrhoids will present with a purplish, as a purplish mass because the blood is pooling there. If they presented within 72 hours, then you can consider excision, but after the 72 hours, you want to manage conservatively. So the reason why I mentioned painless painless in hemorrhoids is because that helps us differentiate between hemorrhoids and anal fissures. Anal fissures are tears in the submucosa and mucosa mucosa of the anus, and it causes a lot of pain. It's painful when you go poop, when you empty your bowels. Sorry. If the symptoms have been present for less than 6 weeks, then it's an acute anal fissure, and if it's longer than 6 weeks, then you call it a chronic anal fissure. So features: painful painful emptying of the bowels. There's also bleeding, bright red again. The tears normally happen in the posterior midline of the mucosa, and in chronic anal fissures, you'll develop a skin tag. I'll show you a picture now, soon. Management, again, conservative. You want to give them advice on increasing their fiber, because constipation can cause anal fissures. You can also tell them drink more fluids. Again, give them laxatives if they have to. And then in chronic, you can give them GTN, which is a vasodilator, which helps to heal the fissure because it's a tear, so you want to heal it. You can give them vasodilators, which promotes healing. But if it's ineffective after 8 weeks, you can give them botulinum toxin or surgery. So here's what I mentioned about the classic triad of a chronic anal fissure. So over time, so you have this anal fissure in the middle, and then above you have a hypertrophied papilla, and below you have a sentinel skin tag. So these, the hypertrophy, the anal papilla and the skin tag contribute to the symptoms caused by anal fissures. So they contribute to the pain and irritation during defecation. They can also cause itching, and they also can cause a sensation of a foreign body being present in the anus. So if you want to treat an anal fissure, you have to treat more than just the fissure itself. You want to remove that papilla, and you want to remove the skin tag. That's the best treatment option. So a perianal abscess. So it's a collection of pus within the subcutaneous tissue. There are many glands found in the anus, the body of the anus. No, the anus, sorry. So if one of these glands becomes clogged, it can get infected, and then an abscess can develop. There are different types of anorectal abscesses. A perianal abscess describes an abscess that's just beneath the skin of the anal canal. So it's found in the surface, sort of the anus. Not most of the abscesses are caused by non-specific obstruction, and that causes infection over time. But other causes can be Crohn's disease, trauma, or cancer. And the symptoms include pain around the anus, which is worse when sitting, pus-like discharge, and then swinging fevers. Swinging fevers, if you haven't realized so far, is always typical in abscess. So an abscess anywhere in the body, in the brain, in the lungs, swinging fevers is a symptom of an abscess. Investigations of a perianal abscess is, again, digital rectal examination, which will reveal exquisitely tender and boggy sort of mass on the surface of the anus. And then you can do an MRI or an ultrasound, but they're rarely done unless you have, Crohn's disease. And management is early incision and drainage. You want to drain the abscess. So yeah, here's what I described. It's a abscess in the surface of the anus. A fistula is a connection between the anal canal and the surface of the skin. So this is the most common type of fistula, actually. So it is quite common, yeah, and it appears actually very commonly after an abscess. So if a patient has had an abscess, it can also develop into a fistula, so sort of a tunnel between the anus and the skin. It is also seen in other conditions like Crohn's disease, diverticular disease, and rectal cancer. The gold standard for diagnosis is an MRI, and the management is either a fistulotomy or a set-in suture. So here, as I mentioned, there are little tunnels or connections between the anus and the skin. And yeah, the management is either fistulotomy. So a fistulotomy involves cutting along the whole length of the fistula so that it heals as a flat scar. So, but these are only suitable if the fistulas do not pass through the sphincter muscles, because if you cut through the sphincter muscles, of course, you can develop incontinence. A set-in technique is more is indicated if the fistula passes through the anal sphincter, and basically it involves threading a piece of like material through the actual tunnel. So you thread it through the tunnel so it comes out on both ends. You tie the piece together and then you leave it in because that promotes healing. So you want to make sure that the fistula heals, the tissue heals by itself, and also if there is an abscess or anything, that it drains through that opening. That won't be corrective. That just helps for the thing to heal. But what you can do over time is sort of, so you have the material, you're tying it together. If over time you make the closure smaller and smaller, you can actually just cut off the other end of the tunnel. So if I don't know if I've described it very well, but I hope that makes sense. So now some questions. So a 55-year-old woman presents to her GP with a 2-month history of bloated feeling and crampy abdominal pain. It improves when she opens her bowels. She hasn't noticed any blood in her stool, however, and she has not noticed any changes in bowel habits. What is the most appropriate action for the GP to take? Well, in this case, I believe the answer is wrong because I checked the NICE guidelines, but it's urgent CA 125. I think the more appropriate answer is an urgent fit test. And this speaks to the guidelines around colorectal cancer management, and that is that any person aged 50 or older with either rectal bleeding or abdominal pain or weight loss should do a fit test. And then if they have a positive fit result, then they should be referred to an urgent 2-week wait colonoscopy after that. So next question. You are asked to clerk a 55-year-old gentleman on the surgical ward. On examination, you note that there's a stoma present in the right iliac fossa. On closer examination, there's 1 lumen present, which is flushed to the skin. The stoma is active and productive of feculent matter, and there does not appear to be irritation to the surrounding skin. Given this information, which condition is the patient most likely to have in their past medical history? So again, I think this question isn't the best written, but I'll go through it quickly. I think this is a good approach with any question like this regarding stomas. So first of all, we know that the stoma is present in the right iliac fossa, okay? We know that there's 1 lumen, so that means that it's an endostomy. There's not 2 lumens, like a loopostomy. There's 1 endostomy opening. We know that it's flushed to the skin. That means that it's likely the colon, the colostomy, because remember, an ileostomy is not flushed to the skin because the small bowels has all these acids that can be irritant to the skin. So you want to make sure there's a spout in ileostomies. Colostomies can be flushed to the skin though, because there's no that much irritation to the skin. It produces feculent matter, so that sort of also agrees with the fact that it's probably a colostomy. And again, yeah, no irritation to the surrounding skin. So if we go through these, ulcerative colitis, so ostomy procedures in ulcerative colitis are used for curative methods. So because ulcerative colitis only affects really the large bowel and the rectum, removing the large bowel and the rectum cures ulcerative colitis. It is a definitive management of ulcerative colitis. However, you won't get like a colostomy, you'll get an ileostomy because you're removing the entire colon. So it's definitely not ulcerative colitis. Perforated diverticulitis, yes, could be. He is 55-year-old gentleman, again, as Martha mentioned. Diverticulitis is sort of like the appendicitis for older people. The only thing that makes me question whether it is, though, is that the stoma was present in the right iliac fossa. In diverticulitis, you do a Hartmann's procedure normally, but that's in the left iliac fossa. So that sort of makes me question number B. C, again, colorectal cancer, you wouldn't have a right iliac fossa opening normally, so that removes, because the opening in colorectal cancer is, the ostomy opening is in the left iliac fossa. Celiac disease, I've never heard of an ostomy being carried out in celiac disease, so it makes it very unlikely. And again, Crohn's disease, it's more conservative, like it's symptom management in Crohn's disease. You don't see as many ostomies in Crohn's disease. It can be considered, however. But given that he's, again, a 55-year-old gentleman, the most likely one is perforated diverticulitis, and that's the answer. Hartmann's procedure, again, I think the ostomy opening should be in the left iliac fossa. So I'll just mention that. So a 49-year-old man books an emergency appointment at his GP practice with a 1-day history of bleeding from his back passage. He has not noticed any weight loss and has not experienced any abdominal pain. He describes noticing a small amount of bright red blood on the pan after opening his bowels at night, but denies any pain on defecation or in his perianal region. Given the likely diagnosis, which is the single most appropriate course of action for the GP to take? So let's go through this quickly. So 49-year-old man with bleeding, no other symptoms really, no pain. That makes hemorrhoids the top differential, because if it was bright red bleeding with pain, that would be an anal fissure. So painless bleeding after emptying bowels makes hemorrhoids most likely. And the most appropriate course is, of course, E, dietary advice, because conservative management is you want to go through a list of So first you want to try conservative. If that doesn't work, then you can try something else. But conservative is always preferred. So number 4, a patient presents to A&E with sudden onset of abdominal pain. The A&E doctor arranged an abdominal X-ray, which is shown here. Given the most likely diagnosis, which is the following most appropriate investigation. So this is an acute abdomen picture because this patient presents with acute sudden onset abdominal pain. This abdominal X-ray is showing a large intestine obstruction, because as you can remember from Martha's presentation, these are haustra that are shown. The small intestine valvulae conviventes, they go through the entire small intestine. So these haustra, they only go through like part of the intestine. So we suspect a large bowel obstruction. The most appropriate investigation to perform next shouldn't be some sort of laparotomy at this point, because there's no sign of peritonitis in the actual picture. And with any question that says perform next, it's more of like an acute thing that you want to do immediately. So in this case, it would be a chest X-ray, because you want to rule out perforation. With any large bowel obstruction, there is a risk of perforation. So you want to rule that out as soon as possible. And if there's a perforation, you'll see signs like wriggler signs. So there's air in the abdomen. So there's a space between the diaphragm and the large bowel. 55-year-old man presents to A&E with a 4-hour history of severe persistent vomiting. Admitting doctor orders an abdominal X-ray, which is pictured. Given the likely diagnosis, which of the following is the most common cause of this condition? So again, if you look at the picture, from what Martha described earlier, the abnormal bowel is found more peripherally rather than centrally. Also, the haustra, they don't go through the entire bowel. They sort of stop in the midline. They don't look like valvula conviventis. So this is a large bowel obstruction. And the most common cause of a large bowel obstruction is colorectal cancer. So, yeah. 23-year-old female is referred to gastroenterology by her GP with a 3-month history of diarrhea. She undergoes colonoscopy with biopsy, which reveals inflammatory changes in the rectum. Subsequent histological analysis reveals the presence of increased number of goblet cells and Rowstone ulcers. Given the most likely diagnosis, which of the following long-term management options is the patient most likely to be recommended? So, 23-year-old female, 3-month history of diarrhea. Okay, so that sort of brings up some differentials. Is it celiac? Is it allergy? Is it IBD, IBS? In colonoscopy, it reveals goblet cells and Rowstone ulcers. Rowstone ulcers are pathognomic of Crohn's disease. So if you see Rowstone ulcers, then you know it's Crohn's. And then the long-term management for Crohn's is azathioprine. So that's the first line for a stable Crohn's. A 29-year-old patient comes to IBD clinic for 3 months after an operation for stricturing Crohn's disease. She's recovering well after her surgery, but she's now complaining of diarrhea. Given the likely cause of the patient's diarrhea, what additional treatment is the gastroenterologist most likely to offer? So I think this is the difficult question, and I think you have to know a lot about the physiology of the gut and all of that. But basically, when it comes to strictures, the terminal ileum is the most common site for strictures. And so she's had surgery for strictures, so that most likely will be of the terminal ileum. The ileum is also where the bile is reabsorbed, and also where the gastric acids and all of that is reabsorbed. So if you don't have the ileum anymore, then you will have bile acid malabsorption, and this can lead to bile acid diarrhea. So this patient has bile acid diarrhea secondary to terminal ileum resection. And this is managed by cholestyramine. It's a bile acid sequestrant, so it reduces the bile acid in the gut so that the diarrhea isn't there anymore, basically. Okay, so that's all. If you have any feedback, we would love to hear it. We work hard on these presentations, but we always want to do better. So please do give us some, and thank you very much for participating.